also looked at the speckle tracking, where we talked about the bullseye and all that. We also made mention of CMR, so we can use magnetic resonance imaging to do that same thing. And that was more advanced. That will be able to tell you about the fact that the left ventricles are hypertrophied. It will be able to tell you about chamber dilatation. And it will also be able to give you an idea where we talked about gadolinium, and we said that it leads to late gadolinium enhancement. And with that, we are able to tell that it's amyloid. Last but not the least, we also talked about the nuclear scintigraphy, where we looked at the bone picking the dye as well as the ATTR version of the amyloid picking up the dye because it had calcium in it. And then we compare the amount of dye that has been picked up, the radio tracer that has been picked up by the bone, and then the heart. And then we use it to generate the various stages, stage 1, stage 2, stage 3, and stage 4. And we said that when we see patients in stage 2, 3, and 4, then they are likely to have amyloidosis. So this is where we have been able to push to. Now, day 1, I think that the signs of the amyloidosis was set out so that we knew where the fibrils, the proteins and the misfolding and the fibrils were coming from. Given the signs, and then given the fact that we have been able to do the investigations, and therefore we are able to tell that this is likely amyloid, the signs can only be proven by the evidence. And sometimes the body produces certain things and it has no clinical significance. So even though we know the signs of it, it does not cause any disease entity for us to chase it. But this one, we will look at the evidence to see that if these proteins are misfolded and they are depositing in certain organs and we are able to detect it, what is the next? So we look at the clinical evidence or clinical significance of these ones. So the clinical significance will bring us to the disease entity. So if it deposits, what does it cause? And then the significance of it will let us know hitherto how that disease entity behaves in its own environment. For instance, if it's aortic stenosis that it causes, as you see on the board, is it the same like any other aortic stenosis? So we will start from here. So we'll look at how that relates to the heart. Now, the first thing that we need to emphasize here so that we can understand this one is that yesterday I tried to let us appreciate the dynamics of the heart, that the heart has 4 chambers, 2 on the upper side and then 2 on the lower side. The upper chambers are those that actually receive the blood, and the lower ones are those that pump the blood. And therefore, the heart has 2 functions. It's a pump, and also it's a receptacle that receives the blood. Now, after the blood has returned from the rest of the body into the right atrium, it dislodges it into the lungs, and where oxygen is extracted, and then it moves all the way back into the left atrium, where through the pulmonary veins into the left atrium, and then enters the left ventricle, and is pushed out. Now, being pushed out, it has to go through what we call the aortic valves into the aorta. Now, studies have shown, and this is where, evidence comes in. Sometimes when you present evidence, and the evidence is so late, it's so old, then people want to think that science is not reproducible. But if you look at this one, you look at Patel and Young, this evidence is just last year, 2022, that they did this study, and they've been able to let us understand that amyloid, as we know of old and now, is coming into the fore because we are getting more sensitized about it. It's still prevalent with us, and it's still causing damage, and it's still causing clinical conditions, which we have to bring our minds to. So we are looking at aortic stenosis, so that if the blood is being pushed out of the ventricle and has to enter the aorta so that it can be distributed to the rest of the body, there's a valve at that level that prevents the blood from coming back. Now, in the elderly, as they grow, they usually, previously we thought of it as a degenerative disease, and then evidence have now shown that it's a chronic inflammatory disorder, so that some of the elderly patients after 60 years, because of chronic inflammation, which we all know sits in the realm of atherosclerosis and endothelial dysfunction, they begin to develop some calcifications, some changes on the aortic valve. and that makes the valve non-pliable. It becomes, if for want of a better word, it is not elastic, but it becomes thickened. And you get calcium depositing on it, and therefore it is not able to open enough for the blood to go out. And we call that process stenosis. But because it's caused by the chronic inflammation, but science, we hardly change terms. We still keep the terminology of degenerative aortic stenosis. Sometimes we call it a senile because previously we thought that old age was contributing to it, but we understand that it's basically chronic inflammation that leads to it. Now, this degenerative aortic valve was what Patel and Young actually looked at and realized that patients who are over the age of about 60, when they develop this valve and this degenerative aortic stenosis, so that their blood is not able to be pushed out well. We have several types of it. We have the sclerosis, we have the stenosis, and it is graded into different types. But be as it may, depending on the class or depending on the type, it goes through the same processes. So those patients that have the degenerative aortic stenosis are more likely, and they are more prone to develop the ATTR subtype of the amyloidosis. So that what clinical significance do we have here? So that if I'm seeing a patient who is otherwise over 60 years, and I do an echo, and I realize that he has a degenerative aortic valve, the other thing that should bring light into my mind is the fact that these patients are prone to developing aortic amyloidosis, and therefore I may have to start section. So it is one of the red flags that we raise. Because the same group of patients we know are prone to developing myocardial infarction through the chronic inflammation process. So whenever we pick a patient who has a degenerative aortic valve, we also investigate the patient to see if he doesn't have coronary artery disease. I mean, especially the epicardial vessels. So as studies are going on, and people are publishing, and people are finding out, we have also come to realize that we need to think about those patients as possible patients likely to develop the ATTR version of amyloidosis, and that is very important. And usually what is outstanding about this group of patients is that they have very poor prognosis. You see the aortic stenosis, and usually aortic stenosis, as is advancing, it should give you a very high velocity so that if you echo, you see a very high velocity to realize that the blood is under so much pressure trying to come out. But in this group of patients, you do the echo and you realize that they have a low flow, the gradient is also low, and it should strike a chord for you to think about what is the mechanics happening behind this one. Because the heart is not capable of contracting so much to push out the blood. And therefore, even though the aortic stenosis is there, their gradient is low, and then they have a low flow, and therefore we need to look at it. And prognosis-wise, it's not good when they develop that, because you begin to see that they produce what yesterday I talked about, the NT-proBNP, which is a marker of telling us that the heart is under stress. So the heart is under either pressure or volume overload. It's being stretched beyond its limit, and then therefore begin to release this protein into the blood, and therefore we see NT-proBNP. And when it is high in the blood, it is not good. It's telling you that the heart is under so much stress. The other thing that comes up, they also have elevated levels of troponin T. And that is what we use as a marker if somebody gets a heart attack. We test them, we realize that he has high levels of troponin T. But in these patients, without heart attack, they also produce high levels of troponin T. So for those of us in the emergencies where we've got now troponin T and proBNP, we can do it at the emergency. We can do a very quick test, a rapid test, and then we can see. And so every elevated troponin in somebody above the age of 60 should not be considered as myocardial infarction. So you see that people receive aspirin, statin, and then they start a process, and nobody will look into anything further. So high levels of troponin T in somebody above 60 years who hitherto is not complaining of any chest pain, we need to think of other things as part of it. Now, the other significance that he found was that yesterday we spoke about the apical sparing, so that amyloid actually deposits in the mid walls and in the basal segment, and usually spares the apex. And they have used that to generate an equation. So the apical to the mass ratio, that would tell us that this is likely amyloid. But in this group of patients, too, that equation doesn't seem to be the case. So if we do the equation and it doesn't work out, we shouldn't think that those patients don't have amyloid, and that is the clinical significance of it. So it has poor prognosis when they develop aortic stenosis, and this is a problem with the valve. So amyloid can affect the valve. I mean, beyond affecting the wall, where it will cause cardiomyopathy. We can also see amyloid depositing in the wall, and its effect will be seen in somebody who has a degenerative aortic valve disease. Can we move on? So that is aortic stenosis. So it is one of the red flags: low flow, low gradient aortic stenosis. We need to think about amyloid. And also, we talked about the electrical system of the heart, where we use the ECG. So we said that one of the things that you see on the ECG to be able to diagnose amyloid, and usually a bit late, might be the low voltages. So you pick out QRS, that is low, where the limb leads will give you about 0.5, less than 0.5, and usually the chest leads will give you less than 1 centimeter. Now, beyond that one, there is also arrhythmias. And when we talk about arrhythmias, it's just about the generation of impulse in the heart and also the conduction of impulse in the heart. So most arrhythmias is either you are not capable of generating your impulse. Usually the body generates impulse of about between 60 and 100. And that is transmitted down through the AV node into the His bundle and all that, so that your ventricle can contract. And usually the atrium and the ventricle, beats in synchrony, so that you will be able to get the atrial contracting first, and then it rests and the ventricle contracts. Now, this variant of amyloidosis can get deposited, and it doesn't usually affect the production of the impulses, but the conduction of the impulses. So usually leads to a conduction abnormality in the heart. And what does it lead us to? So most patients who have these conduction abnormalities, they present to us with low heart rates. So that even though it's being generated by the atrium, the response of the ventricle is usually giving us a low heart rate, or either that conduction cannot come down into the ventricle. So we see them having first degree AV block, second degree AV block, and third degree AV blocks. Usually by the time they get to the third degree AV block, you see their heart rate in the ranges of about 35. No matter what they do, even if they run, their heart rate will be around 35. And because they cannot speed up their heart rate, so when myself and you, we decide to run, your heart rate now may be around 72, but by the time we get down to where we want to eat, your heart rate will be about 120, because it helps you to pump blood. But for this, it's just about 35. So whether they run or they walk, it's still the same. And because the heart cannot keep up with they cannot keep up with that blood which they need, they usually get dizzy and then they collapse. So for those patients, they put in a pacemaker. But it's been found that the ATTR type is quite a type that, leads to the generation of all these arrhythmias, and commonly in the atrium. Once the atrium dilates, so an atrium which are dilated because of amyloidosis, they begin to develop what we call atrial fibrillation. And this is the situation where your RR interval, what we call the RR interval, usually your heart will beat per cycle, and that is really consistent. So it gives a consistent pattern so that we can say that this is a sinus rhythm. But in this case, It doesn't give a very consistent pattern. It beats for, let's say, 30 milliseconds, and the next 40 milliseconds is not beating. It beats in the next 50 milliseconds. So you see an irregular pattern. And that is quite a dangerous rhythm because it does not allow the atrium to contract well and push the blood out. And therefore, it's prone to forming a lot of clots because the blood is not moving. It's just like you've taken blood, for those who are lab scientists, and you put it in a test tube. Now, if you take blood and you put it in a sample bottle, in a short while, it clots, unless you have put something in to prevent it from clotting. So if the blood is not moving, and that is why exercise is very important. If you are not exercising, your blood stays still, and it clots. And that is the whole idea behind DVT, Ps, and all that. So in the atrium, if the atrium comes to a standstill, the blood in it also clots. And the danger is not just the blood clotting, but the blood clots, and it begins to throw out of the, so anytime that the ventricle contracts, it's pushing out blood, and that clotted blood can be pushed out, and it gets into the brain, and they develop strokes. So there's so much evidence that about 40% of them develops atrial fibrillation. So you do the ECG, you may not just see the low voltages alone, but you see an irregular pattern, and there are no P waves, and we call it atrial fibrillation. And the significance of it is that there is a high incidence of arterial thromboembolic phenomenon in these patients. So quite a number of them develop strokes. So that my patient who died, he was admitted with heart failure, but whilst he was on the ward, even though he was anticoagulation, he developed a stroke on the ward, and then along the line he passed. So it's quite a common thing. The Okamoto also and his people in 2011 has realized. Now, hitherto we thought that atrial fibrillation was the most common arrhythmia that we were finding in these patients. But the evidence is staggering when it comes to ventricular fibrillation, ventricular arrhythmias, that they also developed a lot. And in fact, ventricular arrhythmias seem to outnumber the atrial arrhythmias. In quite a number of studies, they have looked at it and they have realized that ventricular arrhythmias does about 70% of the arrhythmias that we see. But the clinical significance of that is the atrial fibrillation in amyloidosis, especially the ATTR type. The studies have shown that it seems not to do much in terms of mortality, but its significance is more with respect to the morbidity. So that we see them more with things like stroke, things like atrial heart failure, because atrial fibrillation, apart from causing stroke, is also having for heart failure. What it does is, because your heart is not contracting well, the atrium is not contracting well, it reduces your cardiac output. And you should understand that somebody who has amyloidosis, who is not hitherto contracting well in the ventricle, would need a lot more blood to be able to increase the stroke volume. But when you have atrial fibrillation, about 30% of the blood that comes into the atrium does not get into the ventricle. And therefore, it cuts down the little that they will otherwise get. And that is what sometimes leads them into heart failure. In 2011, they also found, with ventricular arrhythmias, the only way around, yesterday I mentioned, is that we need to put an implantable cardioverter defibrillator, so that anytime it happens, you get into a VT or a VF, it shocks you. But then, prognostic-wise, they realize that a lot of ICDs in these patients don't give any benefit. So you need to then look at the phenotype of the person. How bad is the symptoms before you can decide. Otherwise, 70% of those patients will require an ICD. If I put a Holter on a patient who has the ATTR version of cardiac amyloidosis, 70% chance that I will find a non-sustained VT. And once I find a non-sustained VT, his symptoms alone requires that I put him on an ICD. And one ICD costs about 70,000 Ghana cedis. Right? An ICD, if we give you an ICD, it's about 70,000 Ghana cedis. The pacemaker costs 60,000 Ghana cedis. And then an ICD about 70,000 Ghana cedis. So you work the maths, and then you see whether it's important to put all on them. It's life. But at the end, even though we can give them an ICD, they looked at it and they realized that prognosis does not change much with an ICD. And therefore, we will only give it to a patient whose symptoms are commensurate with what we are seeing. So quite a number of them will have non-sustained VTs, and they may not be symptomatic. But for a patient who is collapsing, it's important you give an ICD so that he does not pass away. All right. Can we move to the next slide? So this talks about the same atrial fibrillation and the fact that its impact on mortality is actually low, but the highest burden of atrial fibrillation impacts the morbidity in terms of heart failure and also in terms of arterial thromboembolism. Can we go? Yeah. And if you look at the various variants, so you look at the wild type and also the hereditary type and the light chain type, you realize that among the three, there's more thromboembolic phenomenon in the ATTR wild type version, and then the AL comes in. So the ATTR version, you need to open your eyes when you have patients on atrial fibrillation, patients who are having atrial fibrillation, and put them on anticoagulants. So the way to prevent somebody who has atrial fibrillation from getting a stroke is to put on a drug that would thin the blood, and otherwise lead to the body's own fibrinolytic mechanism breaking down the clot which has been formed. So all these patients will require that you put them on anticoagulation because we are trying to prevent a lot more morbidity effects. So you put them on anticoagulation, and you to a large extent prevent them from getting a stroke. We have so many medications that we use, and commonly in Ghana, in terms of costs, warfarin is very good. Patients are able to buy warfarin at any time. The newer ones work well. I mean, they are the best in terms of rivaroxaban, dabigatran, and those ones. But there's only a few patients who are able to afford, because if I have to add an anticoagulation to your medication, and I'm choosing the newer ones, at least you are coughing about 1,000 cedis a month for that drug. So you look at these pensioners and all that, but at least warfarin can do the job. So for most patients who can't afford much, we keep them off warfarin. The issue is the bleeding risk on warfarin is a little higher compared to the newer ones, but the choice is always made based on the patient's pocket and then availability. Okay, can we move on? So moving from the arrhythmias, the other significance, clinical significance that the ATT type poses on us is it causes cardiomyopathy, and that is what we spoke about yesterday, how to diagnose that one. The form of cardiomyopathy it does, there are several forms of cardiomyopathy. So cardiomyopathy, we are actually talking about the heart muscle itself being diseased, so that it is not from outside. When somebody has hypertension and the heart is diseased, we don't say it's a cardiomyopathy. So hypertension causing a heart disease is hypertensive heart disease. If somebody has a disease of the precardial vessels and he develops, let's say, a myocardial infarction or a heart attack, we call that coronary artery disease. So that is a disease affecting the heart because the coronaries are not working. But when it comes to cardiomyopathies, we think primarily, a greater part of the time, the heart muscle itself is diseased. And so, like we said, the signs of amyloidosis shows us that there is deposition of the amyloid fibrils in the heart. And it actually tease apart the cardiomyocytes so that it increases the interstitial spaces and it deposits in the middle. Now, the heart muscle in a normal person should be elastic, just like you have a rubber band. It should be able to, stretch and recall back. And that is how the blood comes in and the blood is pushed out. But in amyloid, this elasticity is actually lost. So the type of cardiomyopathy that they develop, the elasticity is lost, and therefore filling becomes a problem. And it's not just the filling that becomes a problem because they are not able to relax, but because you have sort of disintegrated the cardiomyocytes, because they actually forms what we call syncytium. The cells are joined to each other that when this one contracts, it goes on through all the rest. But once the fibrils deposits, these cells separate out, and therefore their capacity to link up goes down. And therefore, just the relaxation goes down, and also the ability to contract goes down. And that is the type of cardiomyopathy they have. We call it a restrictive kind of cardiomyopathy. Restrictive because it does not allow filling, and therefore cardiac output would eventually drop. So we need to know, what does cardiomyopathies do? So when somebody cannot contract, when somebody cannot relax, the cardiac output goes down, the stroke volume goes down, and the cardiac output, which is the stroke volume times the heart rate, also goes down. We begin to classify them based on what or how much they can do. So, for instance, if I choose 4 patients and I let them walk from here to the gate, I can assess everybody's heart function. And that is why you see sometimes we encourage that you should exercise. Now, exercising does not just help the heart, but it also helps you so that anytime your heart is not functioning well, you can detect it. So what the body does when the heart is not functioning well, it does is that it puts you into a state where you don't work so much. So if you walk a little and you get tired, what will you do? Naturally, you will slow down. And so there are quite a number of people who are walking on the normal, they have their normal pace, walking at maybe, how would I put it? Maybe they take about 10 minutes to get to this door. And for them, it's normal. Somebody will have to take 5 minutes to get to this door. He has found it to be normal. But when we calculate on the average between this door and myself, it shouldn't take you more than half a minute. But your body reduces you to how much energy you have so that you walk from here to here 10 minutes. You consider it normal. You won't feel a thing. But another person will use 5 minutes. Another person will use 2 minutes. Another person will use 1 minute. Another person will even run, and you'll get there. And therefore, when I have to classify all these patients, I will tell that the one who's able to run to this door in just 2 seconds has the highest function. You cannot run. You walk in 5 minutes, so your function may be mild. And the one who has to take the whole day to walk from here to there, I will consider him to have a very severe heart dysfunction, right? And by that, we have put them into various classes, and we call something the New York Heart Association. And that is a functional classification. And that one, I don't need any investigation. I don't need a lab. I don't need anything. Once I ask you to walk from here to here, I can tell what is your function. And so, for normal day-to-day activity, when I was coming here, I had to dress up. I had to comb my hair, I had to wear my shoe and all that. If somebody cannot do this activity, so you see some people at home, they have to be dressed. Because if they decide to wear even a dress, that is like 10 minutes. So when you can perform the normal day-to-day activity, which is at rest, you are not exerting yourself. You are going to take a shower, and then you ask for a stool and sit down, and you can be in the bathroom for 3 hours. It tells that your heart is very bad, right? At the same time, when I have to walk for so long a distance before I get tired, like the one who gets tired at rest, then my heart function is a little better than the one who has to sit, and he's sitting down and he's even tired. When I have to maybe run for so long a time, because if I ask all of us to run to the gate, we can all run to the gate, but we will get tired. But you begin to realize that halfway, somebody will stop. Do you understand? Halfway, somebody will stop. and then somebody will get to the end. And somebody, after even getting to the end, he's not tired. He can run to maybe the runabout before he gets tired. These are all different heart functions. And therefore, we have a parameter to assess whose heart function is good and whose heart function is bad. So the one who is not able to, who has to do something strenuous, not the usual strenuous activity, less than the strenuous activity, we will all get tired. But he gets tired, we'll put that person in stage 1. And then the one who does less than any required activity, so normal day activities, is actually getting him tired, we'll put that person in stage 3. But if you are not doing anything, and you are sitting down, and you are breathless, you are tired, then your heart function is so bad, we put you in stage 4, so that even breathing is a problem. And those are the people that they come to the hospital and tell us that they are laboring when they are breathing, because your breathing should not take you any energy for you to breathe. Do you understand? So when you meet a patient who you can see that after he's sitting, he's laboring to breathe, that patient cannot be at home. He needs to be in the hospital. And that is what this cardiomyopathy, these are the things that it does. Those are the presentations that it brings to us. So if anybody on echo has a thickened heart, thickened left ventricle or right ventricle or both, that patient is classified as a patient who has we suspect to have a certain form of cardiomyopathy, and we need to look into it whether it is ATTR cardiomyopathy. And these are the clinical phenotypes and the disease it brings. And in terms of prognosis, different cardiomyopathies have different prognosis. If somebody delivers, for instance, we have what we call the postpartum cardiomyopathy. Some women deliver and then their heart becomes big, and then they get into heart failure. But that one, we say the prognosis is good. If the patient doesn't deliver again, the heart tries to recover. But this is unlike amyloid. As long as the fibrils get deposited, at least for now, we don't have evidence, especially the ATTR type, that there's any drug that is able to take out the fibrils. There are studies ongoing trying to see whether we can reverse those fibrils, but the evidence is not there yet. So the prognosis stays poor. And that is why sensitization is going on for us to pick them early so that we will prevent the cardiomyopathies from happening. Let's go. Among the other thing is about the cardiac amyloidosis. As in, previously we thought it happened more in men, so that the men above 60 years were those who are getting amyloid. But a lot of studies have also come out to show that women equally get amyloidosis. And except that women have it a little late. So from 60, you may see a man with amyloidosis. But by the time they are almost 70 and 80, the ratio is the same. Women also have amyloidosis, cardiac amyloid, just as the men. So we should not put any sex difference when it comes to cardiac amyloid and think that, okay, this happens in men, and this is a woman, it can't be cardiac amyloid. The evidence doesn't show that. And then we have also found, and this is quite recent, this is 2023, Hassan and his friends, people are pushing the barriers of science forward. I've also found that, just like I was talking about epicardial vessels can cause coronary arteries. Epicardial vessels, those are the vessels outside the heart that feed the heart. They can cause people to have a heart attack. Evidence have been found that people who have ATTR amyloid also have a higher predisposition of developing the obstructive disease. So the epicardial vessels are likely to have atherosclerosis that gets blocked and can also equally lead to myocardial infarction. But what has been found is that the ATTR variant are able to deposit in the small vessels in the heart, small vessels. And those ones will shut off the blood supply to the heart. And therefore, they are not precluded from having myocardial infarction. On the contrary, their chances of developing myocardial infarction is rather high. And then the other thing that we need to know is in terms of, amyloid also affects, and I'm sure somebody will talk about it, affects the nervous system. But what has been found is that those patients with the ATTR version, they develop a lot of parasympathetic events. And that is the autonomic dysfunction that comes with amyloid. So that the heart has a problem. And usually, because the heart has a problem, it's not capable of pushing out blood. So most of the time, their BPs are low. But added to that comes autonomic dysfunction. And you know that autonomic nervous system is what regulates almost all the important function organs in the body in terms of the respiration, heart rate, availability of your bowel to move and all that. Now they come complaining of symptoms of sometimes they get palpitations. Now when they say they have palpitations, our mind is quickly drawn to the heart. When they tell you that they have difficulty emptying their bowel or they have diarrhea, your mind is quickly drawn to the GI system. But when they tell you they are sweating a lot, then you kind of think, okay, metabolism is high and all that. But these can equally be the effects of the autonomic nervous system, so that it may have nothing to do with the heart. So we have said, yesterday we said that if somebody is hypertensive, and then all of a sudden you realize that the person's BP are very much controlled even without the drugs, you should draw attention to the fact that he may have autonomic dysfunction. So some patients are able to tell you that, oh, previously I was hypertensive, but when I went to see the doctor, he said the BPs are fine. And so he took off the drugs. And it's been 2 years. I've stayed without drugs. So for those people who become normotensive when they are hypertensive, previously hypertensive, or their BPs are beginning to go down, they come telling you that on the drug, I'm feeling dizzy. On the drug, I'm feeling dizzy, and you remove it. And then they are fine. You should think that autonomic dysfunction is actually what is playing out. So when their parasympathetics and sympathetic system is not working, we begin to realize that they dilate. And therefore, when they dilate, actually their afterload goes down. And when it comes to physiology, the afterload goes down, and therefore their pressures come down by itself. But then it's a problem that we need to look at. And therefore, sometimes the presentation of the cardiac disorders may not really be from the cardiac. Palpitations, per se, may just be that the parasympathetics have been downplayed, and therefore sympathetic have taken over, and therefore their heart seems to be kicking in more. But the problem is the parasympathetic system, right? So all these we have, they have a way of testing. They have what we call the tilt test. We do that tilt test and to tell whether it's actually coming from the heart or it's coming actually from the nerves. All those are investigations we do. But these are the clinical significances of these things. So somebody has a cardiomyopathy because of amyloid, and also they also develop autonomic nervous system abnormalities. Can we move on? And also, the ATTR type is also associated with a lot more carpal tunnel syndrome. You know, yesterday I told you about the patient I scanned who had the right ventricular dysfunction, and immediately it didn't ring a bell to us until he started complaining about pains and pains, and then some form of numbness in the hands, and we realized that he had stiffness at the wrist, and that was carpal tunnel syndrome. So they have it about 5 times more than somebody who doesn't have any hypertrophic, changes in the heart. So our attention has to be drawn to that. When we see amyloid patients, those who have the cardiac amyloid, we should know that the carpal tunnel syndrome is just around the corner. And the Poppy's disease, which is the brachial biceps tendon rupture, it's not very common. We don't see it much because it's very classic. You see that the tendon of the biceps have ruptured. It's also one of those things that, we may see. And this person, when he ruptures a tendon, it will be sent to maybe the orthopedic. And it may be corrected. His mind will not even come to the fact that it has any connection with the heart. And that is how, they have to be picked. Can we move on? Yeah, and I think Carrie was just trying to find out that it's difficult. There's nothing to actually track genetically if somebody will have the ATTR type. So it leaves us in a very difficult situation. That if somebody, how would we, can we ever predict that this person is likely to develop amyloidosis of the ATTR type? And really, there are not much genetic studies to confirm that. Now, in heart failure is usually the common pathway that almost all cardiac diseases would enter when it's getting to the end. So if somebody has a valve problem, it will finally end in heart failure. If somebody has a problem of the heart muscle, it will end up finally in heart failure. If somebody has sometimes an electrical problem, atrial fibrillation, it will go on, and it will end up in heart failure. So heart failure is not something we are so much happy with, that I've been able to diagnose heart failure and I'm happy as a clinician. No. If I find you hypertensive, as I stand as a clinician, I look at you and I can see the future, right? So sometimes, just like the soothsayers, they say they can predict somebody's future. We see you are hypertensive, and we see the end of the line for you if we don't intervene. And that is why we are in this business of picking risk factors, right? So that we don't leave you in the disease state. So we usually say hypertension is not a disease entity. It's actually a risk factor. If you have hypertension, you can lead a normal life like anybody. If I pick you early and then I control it, you are fine. In fact, it's better when I pick you at a time when you don't have hypertension, but I know that your mother and your father are hypertensive. Then I know that you have a strong predisposition. And therefore, I work with you along the line. I can prolong the time between the time I picked you and the time you develop hypertension, or I can even eradicate it by just telling you to observe some lifestyle changes. And then you may never develop hypertension, or even if it will happen, because genetically you are programmed to, it may happen to you after 60 years. Do you understand? And that is the essence of informing your patients that they need to come to the clinic at least once a year. Because some people sit down because they don't feel anything. They sit down and their hearts are getting bigger and bigger and bigger until symptoms set in. And at that time, we can't do miracles. We can't reverse everything. So that is the picture of heart failure when it comes to amyloidosis. And amyloid, when it gets into the heart, the cardiac amyloid, the prognosis in terms of how long a person can live, we are looking at sometime between 2 and maximum 10 years. The ATTR type, sometime 2 to 6 years. And so to be able to prolong the survival of these patients, it's better we prevent the deposition, right? So the heart-related significance is when I find the patient with amyloid who has already entered heart failure. And quite a number of them, would present to me with preserved ejection fraction. So I do the ratios and they are fine. But the absolute cardiac output is reduced. So I should not be deceived to think that somebody brings you the echo and the echo is 60% and then you are happy. The absolute amount that they are pushing out is reduced, and therefore they are prone to developing heart failure. And so just like when Dr. Pia was talking, he talked about the 3 variants, the wild type and the 2 variants. And one of it, the V1221, has been actually registered in West Africa, and it's associated with heart failure. And that is one of the things that, we love to look into, because they found it in African Americans out there. And African Americans are just our brothers and sisters, right? Now the nurses are going so much. So very soon they become African Americans, right? Because they are going so much. They are going to give birth. They are not coming back home. Me, I know they go and they are not coming back. So they are going to marry. They are going to give birth there. And they will become African Americans. And therefore, the gene here is translocated. Is transported there. So once they find a gene in an African American, they can trace it back, and they realize that these are quite a number of the people that were sent from West Africa. And therefore, it's important we carry on the study in our local environment to find how many people may have this gene and how many people are waiting and to be 60 to develop amyloidosis and all that, so that if anything can be done to stripe out the gene, we will do point mutations. Now a lot of science have advanced. If there's anything to slow down the productions, we will do. If anything to stabilize the protein, we will do. Do you understand? Before we get it into that one. And that is what I think Dr. Pierre will try and do. Will talk to us about the meta-analysis. And that one is just a pool data that they have done, a lot of evidence that people have, presented and put on, and then pulling them together and bringing a scientific perspective to it in terms of statistical significance. So there is a lot. But each of them separately does not hold the answer to what we are looking for. But when you pull them together, then it becomes stronger. Then you can then get some statistical significance of it. What I presented has a lot of systematic review, so that we take a study and then we do scholarly, summaries of it, and then we say it in perspective that this is it. But the meta-analysis holds the key to a lot of the things that we are talking about. Can we go to the next slide? So this is what I talked about, that when you have heart failure, I can diagnose you clinically. So heart failure is not diagnosed by echo, and it's also not diagnosed by ECG, not by chest X-ray. Do you understand? Those are supporting investigations. But if somebody is in heart failure, the symptoms tell. So the left heart symptoms are there, and the right heart symptoms are there. And those symptoms are just there to classify that is a right heart failure, this is a left, or we have a combination of both occurring. But it all boils down to function. What can you do? What can you do? So that is why we say it's a functional classification. So there's New York Heart Association 1, 2, 3, 4. Right? And we say that ordinary physical activity does not cause any fatigue, dyspnea, or palpitations. So if you don't have any symptom, you can do everything. You can walk up the stairs in your house, you can dress yourself, you can walk, and you are not getting any symptoms. We say that you are in a New York Heart Association class 1. And we have some people who have heart failure like that. So somebody has amyloid, you do echo, you can find it, but then symptom-wise, he has no symptoms. You put this patient in a New York Heart Association class 1, so that we have been able to pick that the person has a structural abnormality, but it's not limiting him in any way. We have that group of people. And those group of people, when it comes to heart failure medications, usually we will not put them on heart failure medications. We will reduce their risk factors. So for instance, if it's hypertensive, I will give antihypertensives. If it's diabetic, we give antidiabetic medications. And then we monitor them. But those people who do this activity, they climb upstairs, and all of a sudden, they are breathless, they are complaining of palpitations, some even get chest pain. We put them in class 2. All right? And then class 3 patients, they also get fatigued, less than the ordinary activity, so they can't climb stairs. they can't climb stairs, but maybe dressing themselves up, they are tired. But when they sit and rest for a while, they are fine. So those are the people, if you tell them, let's go to the hospital, they will say, oh, I'm fine. Those are in heart failure class 3. And then those that you see obviously before your eye, he's not doing anything. So as we are sitting here and you are listening to me, you see that the person is short of breath. He has to use the other accessory muscles. Because all of us, as we are sitting, we are breathing effortlessly. You don't even realize you are breathing. But then the person is using another accessory muscle that he has to augment his breathing. Then that patient, we put that patient in New York class 4. And those patients, they can't stay home. Actually, the 2 and 3 people, they all have to be in the hospital to be given some treatment. The 3, usually when they come in, the doctor is able to start something, and in 2-3 hours, they are fine. We give medication to continue, and they go home and come and see us periodically. But the 4 definitely will need admission for his hemodynamics to be sensitized. So I think I'll end here. At least we have been able to understand that aortic stenosis, arrhythmias, cardiomyopathies, and then heart failure are the key things that happen in cardiac amyloidosis. And mind you, for any form of amyloidosis, if there's heart involvement, the prognosis is bad. If there's no heart involvement, you are otherwise okay. But as long as the heart sets in, the prognosis is bad. Thank you.
Another one. All right. We thank Doctor for such a wonderful presentation. If you have a question, you raise your hand, then I'll bring the mic. Questions time, please.
Doctor, thank you very much for your wonderful presentation. My question is not a question, but you talk of most of us, our parents are hypertensive. So those of us who are offspring, you have to advise us. Some of us are here whose parents are hypertensive. We need that advice for ourselves.
Pardon, can you come again? I didn't kind of hear the question.
I was saying that most of us here, parents are hypertensive, and we are their offspring, so we need the advice.
So just that this is beside this topic. So just like hypertension is a risk factor, not a disease entity per se, and any hypertensive can lead a normal life as long as it's being controlled and then he goes on regular review, right? So the only problem we have with a lot of hypertensives is that as long as he sits home and check the BP, and the BP is fine, he doesn't sit in the hospital for his regular review. Do you understand? Because he sees the BP is fine, I can continue my drugs. But some of them continue the drugs and they get the side effects of the drugs. And sometimes to the hypertension, before we diagnose it, quite a number of them, it may have caused some dysfunction to some organ one way or the other. And therefore, that is why they come in on review for us to check. Sometimes the protein in the urine has already gone up. And then he will sit at home, BPs are fine, till he comes with a full-blown kidney disease. So we will not advise that even if your BP is fine, and your doctor says come in 4 monthly or 6 monthly, you have to abide by that. And the other thing is the side effects of the drugs. Some of the drugs also interfere with a lot of things, and therefore they need to go for that one. Recently, there's also a lot more that they do at the clinic. Some clinics have established what we call the rehabilitation aspect of medicine, so that you are old, like your mother may be about 65, he's not walking much at home, but the moment he comes in the hospital and they put them in those rehab programs, you realize that they come alive again. And therefore, these are the important things that we need. So the first thing is to make sure it's diagnosed if they have hypertension, and then they are put on the right therapy, and then they go for regular reviews, and then their lifestyle management is also done. If it's done, they are fine. And then we look at the other comorbidities that comes with it, right? Mm-hmm. What do you do? Yes, so that is what you have to ensure. You have to ensure that your mother, right? If it's your mother and your father, you have to ensure that at least they have had a BP check. Yes, so that's what I said. So I think when I was talking, I mentioned it, that your parents, when one parent has hypertension, is a risk factor for the rest of the family. So what you do is that, depending on your age, most of the time, because now we are sitting in a clinic and we are beginning to see that epidemiology is changing. Hitherto, we thought that what they call the essential hypertension or primary hypertension was starting around the ages of 45, thereabout. But we see quite a number of 25 years persons, and they've come with BPs, and we've done everything to try to find a secondary point, and we don't have, but there's only a family history. So I advise my patients that from the age of 25, you walk into the hospital, you check your first BP. If your first BP is fine, and your mother or father has hypertension, then you can come do a yearly check, right? You can do yearly check. And then you, knowing the fact that you are predisposed to lifestyle modification is the best. So low salt diet, exercise, and then maybe yearly checks. You should be fine. Because early detection is what makes the difference. Yeah.
Hello, doctor. Thank you for your great presentation. And I want to add a comment about heart failure. You say that you can diagnose this heart failure by looking at a person, but don't forget about anemia, because anemia share most of symptoms with heart failure. I have to struggle in my hospital with my young colleague who are nephrologists. First, when the person is coming with shortness of breath, oh, madam, it's a pulmonary edema. I say, oh, take your time to examine the patient, because look at her eye. Maybe it's a part of anemia. Don't forget about anemia. It's my comment. And second, I'm agree with you. It's important to prevent disease. We have to open this type of out clinic in our hospital. Not to treat, we have to prevent. And prevent the disease should be a way for Africa to reduce amounts of care about disease. Because most of the persons have to go to hospital when they are sick. They did not think about going early to prevent disease. We organize each March World Kidney Days. And in my country, most of the persons who come for screening are sick persons, not healthy persons. You have to make some communication about how to prevent disease. It's very, very important. Thank you very much.
Yeah, thank you very much. And that's a welcoming comment. So, for instance, so I say that heart failure is a clinical diagnosis because before you make a clinical diagnosis, you need the symptoms and the examination together. And then the shortness of breath, there's a difference between the shortness of breath for anemia and then for the heart failure. And that one, if you do take the history well, you pick it. Now, when heart failure, the person has shortness of breath, they begin to develop what we call the high pressures in the left atrium. And therefore, sleeping at night or flat becomes a problem. Now, if somebody has anemia, I can sleep flat. You'll be short of breath, but I can sleep flat. But heart failure, they begin to develop. giving it high output failure. So you examine the patient and then you listen to the patient's symptoms and you put it together and you make a diagnosis of heart failure. And then it's important you pick it because these are comorbidities to it, right? So somebody can have heart failure and it's purely caused by anemia, and then you have to pick it. And I think personally I agree with you. That's why I say that if you make a diagnosis of heart failure, I am not happy. Do you understand? But I think now medicine has advanced so much that now medicine cannot be the old practice where, then there were big consultants and one man would tell what the patient should do. And then if he says the patient should stop salt, that is all. But now medicine has become very inclusive. You can't take the decision without the patient. And it's a group practice. So we have to move. And for me, even though I'm a heart specialist, the point is, if you come to me at the extremes of the disease, I'm not happy. Do you understand? I can make more money from you, but I can't help you. So if, like I said, if I'm putting a pacemaker, that will cost like 70,000. My percentage in it at the hospital will go high, but that is not good for you. Do you understand? It will be good you come at the stage where she's talking about. You are at this where we screen and we find that there's a risk factor or you don't have anything, and then we advise you on the way forward. Do you understand? So let us all, and it can be, it has to be a collaborative thing, that if all health professionals, the health workers, begin to move towards the preventive, because you realize that most hospitals don't even have the public health section. Like most of hospitals don't have a public health section, but they hold the key to preventing diseases. So we work in tandem with them, and then we prevent diseases. So let this be maybe the mantra that we have as we live here, that we work to prevent diseases, right? And I believe a patient told me one time, I went to give a talk somewhere, and he says that sometimes it's also not their fault, because when they come into the hospital and they are not sick, and they come and tell the doctor that they want labs or something to do, then the doctor is angry that we are seeing sick people, you are... And somebody mentioned it to me, that he walked into a hospital like that, and the doctor said, "Nah, we'll be on your open." So we need to realize that, yesterday, our pathologist told us that death is not the end of the disease. So should we know that it is not only sick people who come to the hospital. So somebody can come and start the process, and then we prevent him from getting it. In fact, I have a private clinic, and I advise, if I see you as a hypertensive, I tell you that, look, your family should come. Do you understand? Because I need to screen and do it, and I know I can tell everybody what he needs to do and be fine. And that is the practice we should be looking at.
Okay, thank you, Doc. You mentioned that you had a case, heart failure, and later resulted in stroke. We had a case like that in our facility. Patients came with heart failure and pulmonary edema. Patient had dyspnea and pedal edema. And along the line, they asked that he undergo dialysis. I want to know how dialysis is going to resolve the condition. People were saying that the dialysis can help with the pulmonary edema. I don't know if you do that at your facility. And I want to know if it could be TTR, because later on the patient developed stroke and died. Also, the ICD and the pacemaker, I want to know if it's 100% or if there's a side effect, as in helpful. 100% helpful.
So I think what you are talking about lies in the realm of mommy. I'm sure the patient had heart failure and had other comorbidities with it. So they will mention hemodialysis. Is that what they said? Or they said ultrafiltration? They said hemodialysis. Yeah, so hemodialysis, usually they do for kidney issues. And sometimes it's difficult to tell. Sometimes the kidney would have started and affected the heart, or sometimes the reverse. The heart would have started and also affected the heart. So we have something called the cardiorenal syndrome. So when it's acute, then we think that if the patient is in the hospital, the acute phase, if it's really bad, potassium is going up, your urea creatinine is going up, there's so much fluid, and you are sinking in it. There's room for hemodialysis to at least stabilize you in the acute phase. So maybe that's what they because it will equally take out the fluid, and then the heart failure would improve. But that is not a treatment for the heart failure. I guess they were looking at making the patient stable with respect to the kidneys so that they can buy time to do the other things. And if they realize it's chronic too, then you may have to continue on the hemodialysis for long. So it was not geared at treating the heart failure alone, but I guess it was with that one. So your patient, like we said, this picture is what we are talking about. It's difficult in this case to tell whether it was ATTR or it was amyloidosis first. Then we go into the typing. So I'm sure the doctors will have done an echo when he came in. Because a lot of things, once you get any form of cardiomyopathy, you can end up having a stroke. You can end up having a complication. So maybe he had a dilated cardiomyopathy, developed a thrombus, which you threw into the brain to become a stroke. So the first thing the doctors will have to do is to do their ECG and then the echo. And then, depending on the risk factors that were there, they will begin to think about the possible causes, right? Mm-hmm. But what we are bringing up is that when you find patients who are above 60 usually, and they are presenting with heart failure, and there are no clear traditional risk factors, which is putting them at that predisposition, then you need to think about it. Suffice it to say that amyloid, even there's not all amyloid cases that they get thickened hearts. Cardiac amyloid. A few of them, their hearts are not thick. And therefore, it becomes a diagnostic challenge. A few of them, their hearts are not thick. But by and large, a greater part of it, we should be able to pick them.
All right.
Yeah, the pacemaker is used for, basically, it's for correcting bradycardias. So if your heart is not able to keep up with the 60 to 100 that a normal person has, and it has dropped all the way to like 35, and the person is symptomatic, at that point, the patient begins to feel dizzy, pre-syncope, or excessively tired, then we recommend a pacemaker. So that one, it solves the problem, the electrical problem. It won't solve the structural problem most of the time. And pacemaker, if you put a patient on a pacemaker for a long time, it also has its own effect because sometimes it disturbs the synchrony of the heart. And therefore, sometimes over 10 years, 15 years, they develop atrial fibrillation along the line. So we look at all those dynamics before we start.
All right. Doc, thank you very much for a lot of education on the heart. My question is, can surgical procedures also help in getting rid of these proteins in the heart? Can surgical procedures help in getting rid of these?
Somebody's going to do the treatment, right? Dr. Pierre, somebody's going to do the treatment, right? Yeah, somebody's going to do the treatment.
Yes. And then my second question has to do with, you made mention that exercise is a good measure for the heart function. But I can realize that for the health sector, we do have issues getting time for ourselves. Is there any measures apart from exercise that we can do to help our heart function well?
So you see, at the end of the day, what I tell my patients is this: it's not just health sector who doesn't seem to have time. All of us as human beings, everybody don't have time. If we give you 24 hours and we add another 24 hours, you won't have time. Mm-hmm. So it will not be the cardiologist or the nephrologist saying that, oh, for me, my work, I have to work 24 hours a day. You'll break down, right? So you should plan your time and have time for exercise. And usually we are not recommending much such that you won't have time. We say that the minimum that will be able to keep you and that will let you realize if things are even going wrong will be to do 30 minutes of walking a day for about 5 times in a week. In fact, the new studies have even come down to the fact that American studies have shown, some American heart association, that even if you do 15 minutes a day, at least of walking, 15 minutes a day of walking, and just that this walking, we are not talking about there, we are talking about brisk walking. So if you do 15 minutes a day, right? So you can't tell that you work and you can't get 15 minutes a day to do that thing. If you can't get it, then you put your own self at risk, right? So at least 15 minutes a day, you should be able to walk. That's the minimum. And if you can do more than that, you do. And I keep telling my patients that the elderly patients, like her mother, as she's saying, if you're hypertensive, and you tell the person to walk just like that, I'm wondering, where am I walking to, the adults? So I tell them, when you have church programs in the evening, go. Because they are staying in a community. So the community church is there. If there's a church program, he walks to the program. If your friend lives next door, go and find out how she's doing. And by that, they are walking. They get something which is a bit interesting to occupy themselves, other than just sitting at home. Because away from the hypertension is DVT, is thromboembolism. So you do yourself a good service by advising your mother to get involved in some kind of social activity and then community work. And then with that, they stay healthy. But you, young man, you should be running. Yeah. Mm-hmm.
Okay, a participant have a question here. Does sudden collapse upon hearing shocking news affect the heart? If yes, how does that happen? How does it affect it?
These questions are outside of amyloid. But yes. If somebody are outside of amyloid.
I want to suggest that we direct our questions to this.
Yes.
If you have personal things, please see him after the meeting, so that we don't keep going back and forth.
So that we can continue.
All right, so let's give doctor a hand, then the very last one.
Hello, thank you very much. Please, I want to find out if late onset of maybe asthmatic attack in the elderly can be as a result, or maybe is in a way prone to heart-related disease, because sometimes the symptoms are similar.
Yeah, so that's a very important question. So in the elderly, so just as we know the pathophysiology of asthma, at least for the type which is mostly atopic, we know that it happens in childhood, and as they grow, it gets better. Some even grow out of it. But that atopy still remains. So if they get contact with whatever the stimulant is, it can still trigger it even though they are old. But by and large, what you said is very important, because those patients who have other risk factors, like hypertension, for instance, along the line, they develop what we call the cardiac asthma, right? So if somebody has BP no control for a long time, they can develop cardiac asthma, which is a form of pulmonary edema. And I know they get into hospitals and they rather treat them for asthma rather than check the BP, listen to the lungs and all that. So it can be a presentation. If somebody has amyloid and the ventricles are stiff, cardiac output is low, they also develop similar cardiac asthmas. And that may be something that we have to look at as well. So it's one of the red flags that maybe somebody said he was asthmatic, but now he's old and he's 65, and now he seems to be getting more frequent episodes of wheezing and dyspnea. Yes, we need to look into that and see if the heart is enlarged, it's thickened, and probably that is also amyloid. So that's important, yeah.
All right, a hand. Yes, we thank doctor for that. The next presenter is coming to talk about diagnostic-related significance and some overview of what treatments. And the person to do that for us is Prof. Tabiri. Let's welcome him with a round of applause.
Thank you very much. Thank you very much, Senior Dr. Yao Adubuachi. You see, I'm great, but I'm still calling him senior. Why? Because we attended Prempeh College. And if you see anyone who attended Prempeh College, irrespective of the age, you call the person senior. That is why I say Senior Dr. Yao Adubuachi. Thank you so much. So, we are getting to an end. So this is the time we're going to work together. I'm not going to do it alone. It has to be interactive because I work in a medical school where we do what is known as problem-based learning. And the meaning of that is that you take the students from known to an unknown. So you give them assignment, they go and read, and then they come back to class. Then they tell you what you know. You guide them gradually from an unknown, from known to an unknown. And that is the definition of education. So that is what we're going to do now, so that we're all going to take home the understanding of what we've done so far for the last 2 days, or this is the third day. So we're going to do together diagnostic-related significance of amyloidosis. I'm not going to confuse you with ATTRW, ATTRV. No. Because we are not going to do that. We're just going to try to apply in what we do. So, let's start with the heart, cardiopulmonary. What is the diagnostic significance of amyloidosis? Please, if you know the answer, you raise up your hand. I don't want to pick anyone on spot. So if you and tell me something, what you've heard about cardiac atrial fibrillation, cardiomyopathy, aortic stenosis, cardiomegaly, arrhythmias. So, who can give us idea what we've learned with amyloidosis and relate the diagnostic to the condition? Let's take them one by one. That is, we're looking at the heart. So any volunteer from the room, please don't feel shy. The question is, we want to look at diagnostic relation of amyloidosis in cardiac or cardiopulmonary diseases. What we've learned so far, let's see if we can apply it. You want to say something? Okay, yes. Yes. Thank you very much. Give him a hand of applause before he starts speaking. Thank you so much.
We learned that we have a lot of cardiac cases with amyloidosis. We've learned that we have a lot of cardiac cases with amyloidosis. And in the diagnosis, we heard about echocardiography. Is it cardiography? Yes. Echocardiography. So it means that if you suspect a case of cardiac amyloidosis, then they should do that test to move it forward to confirming it.
Well done. Let's give him a hand of applause. Well done. Bold enough to open the floor, and that is great. Yes. Thank you, sir. Please introduce yourself. Madam, later I'll come back to you and then you reintroduce.
Thank you very much. My name is David Samuel Nigarim from CK Tedam University of Technology and Applied Sciences. And what we have learned I have learned so far has to do with most of the cardiac cases we get at the various hospitals. Usually, clinicians would want to look at certain causative factors without actually looking at a possible cause from amyloidosis. And so, in our attempt to look at some of the causes of cardiac diseases, we should also think of amyloidosis as a possible cause of cardiac diseases. So we should not overlook amyloidosis as a possible cause in our lookout for cardiac conditions. So we should broaden our scope of searching for the possible causes of amyloidosis.
Thank you very much. Let's give him a hand of
possible
applause.
Causes of cardiac diseases.
Thank you very much. Please do it better. Let's applaud people. That is the only motivation you can get from here. So please don't let the applause die down with time. Yes, anyone? Yes, sir. Please. Yes, she's coming with a microphone. Let's give him a hand of applause. Great.
Okay, thank you, Prof. I think I've also learned that elderly patients with aortic stenosis usually have high levels of the CTNT and also the NT-pro BNP levels. And as a result, all those patients have very poor prognosis with the ATTR amyloidosis. Thank you.
So let's give him a hand of applause. Please don't let it die down. That is a motivation. Yes, anyone? Yes, thank you very much. Give him a hand of applause before he starts. Well done. We are all doing very well.
We are saying that at all times we should have a suspicion. If the suspicion is not there, we can't pick it on time.
Thank you very much. Please, hand of applause. Don't let it die down. Yes. Beautifully done. I don't have to say anything else. Thank you for doing my work for me. And so, all the information given to us are what we are supposed to know. Yes, the ATTR or SPD or all those things are very important. But what we are doing here is to create awareness. So, the three information we got from our colleagues says that suspected. So if you got someone who has got bizarre hypertension, cardiac failure, and you use the conventional treatment, and it's not working out, something should prick the brain and say, oh, okay, I was in Kumasi, I was in True Vine, I listened to all these lectures. This could be a possibility. Then you can get help, all these terminologies, put it into perspective, confirm the diagnosis, and then instead of going conventional treatment, you do something else to help the patient. You will not end there. We spoke about screening. So that should also prompt you that, no, this patient that have been able to successfully diagnose amyloidosis-related cardiac diseases, cardiopulmonary diseases, I should refer or need further investigation in the family relations, to see if we can identify the familial type. If not, then it is a genetic mutation. Then going forward, you have to now also screen the future generation of that patient. And I'm very happy Senior Dr. Yao Adu Buachi said, with that, he can manage you, prolong your life, protect the heart, guide the heart, so that you can live longer and be able to put your grandchildren on your lap. That is the purpose of living. Good. So we move from cardiac. We're going to neurogenic. We had a lot of information, diagnosis, things that were said about neurogenic disorders. So that's what we're going to do now. So what have we learned so far? Diagnostic-related amyloidosis in terms of, let's put the neurogenic and then musculoskeletal disorders. Yes, who can come on board? Yes, please. Thank you very much. Give him a hand of applause. Master, you are not doing your work. Oh.
All right. Thank you one more time. I have learned that in our hospitals, we may have cases like sickle cell diseases that present with joint pains. It might not be the case of sickle cell disease, but amyloidosis. And so in as much as we think of maybe like diabetics or sickle cell diseases having a negative impact on nerve supply and all those things, we should as well think of amyloidosis as being a possible cause of these musculoskeletal symptoms, as well as the nerves, peripheral nerves.
Thank you very much. Let's give him a hand of applause. Yes, anyone with any divergent view, we are in a democracy, so please speak your mind. Don't take it home, share it. Yes. Yes, sir. Let's give him a hand of applause. Hey, don't let it die out. Oh. Let's motivate people, please. It's not difficult. It's not easy.
So with the neurogenic, it also have effects on the autonomic nervous system, where it can lead to the orthostatic hypotension and other gastrointestinal tract problems in clients with the autoimmune that effects.
Thank you very much. Yes. Yes, sir. Give him a hand of applause before he starts. Please try your best. It's also exercise. Once you clap, the hand is moving, it's going to improve blood supply. Yeah. So please don't let it die out. Yes.
Yeah. Oftentimes, at our facilities, we get cases of neuropathic pains, and mostly our mind will go to diabetes and be asking about it. Now we know that this condition can also cause such cases of neuropathic pain. And so when they present with it, we need to probe further to find out if it is amyloidosis, and then we track it as well.
Thank you very much. Yes. Yes, boss. Hand of applause, please.
Okay. I think one thing we should also know is that most of the hearing problems, usually the hearing loss problems, are also associated, as my brother here mentioned, with the autonomic nervous system. So we should also take note that not all the hearing problems we encounter in our facilities are just normal. Some are related to TTR amyloidosis. Thank you.
Thank you very much. Yes, any other person? We still have time. Yes. Please give a hand of applause.
Please, I also learned that when Dr. Chem was here, he was telling us that after we've done all
Please, if you speak into the microphone.
investigations, we can also put in some measures like the quantitative and the autonomic system, like introducing a patient to temperatures like the cold and the warm, like that's the other investigations we can also add to our investigations when we are trying to find out if there is amyloidosis.
Thank you very much. Again, well done. Congratulations to all of us. It means we got it. So let's give ourselves a big hand of applause, all of us. Very good. So they said it all. So there's pain, backache, can block where the nerves leaves the spine and compress on it with the deposition of amyloidosis, and that will lead to chronic pain. We need to, we can't say we're screening everybody in Ghana. Screening process is expensive. But then if you have the high index of suspicion, then you're going to pick the odd ones. And once you pick the odd ones, you investigate them, confirm the diagnosis. That will be the basis of future screening of the offspring or the relatives. So well done. So we're going to the next part, and this time I'll give a scenario. 25-year-old male patient presents to you, wherever in your facility, with epigastric pain. What is the first thing that comes to mind? Epigastric pain. What is the first thing that comes to mind? Pastor, you have to be active and running.
You'll be thinking of PUD or GERD.
Okay. Very good. Thinking of peptic ulcer disease. Yes. Any other person? Yes.
Crohn's disease.
Okay. Yes. There's a hand up here.
I can be thinking of heart failure.
Okay. A possibility because the heart is sitting on the diaphragm, right? And if it's enlarged, it can irritate the diaphragm through the central tendon, and then you feel it in the epigastric. So that is fine. Yes. Which hernia? Hiatal hernia. Okay, good. So we've got that. So now let's treat. You treat this patient for 3 weeks. He comes back to you. There's no relief at all of his or her symptoms. What is happening next? Right? You're going to repeat the treatment. So you've done that. The patient comes back to you and say, no, still epigastric pain. The next one is you send it to the endoscopist to do upper GI endoscopy for you, right? So he's done the upper GI endoscopy. Well, he's describing a lesion. Okay? Of course, you've done maybe abdominal scan and you've ruled out a pancreatitis. So you're still concentrating on the PUD. There is a lesion. The endoscopy has taken a biopsy. You send the biopsy to my senior man, and then you said, well, there was a lesion that resembles ulcer, but it's not classical ulcer. If you are lucky and you have endoscopy that can take a picture, you take a picture, print it, and attach it to him. Okay? Remember, you've treated this patient with a conventional treatment for 3 weeks. You repeated it. No results. You've been to Kumasi at True Vine Hotel for 2 days. And it's not pancreatitis, you are sure of that. What are you going to tell my senior man? In the request form, what are you going to write? What are you going to write? You said, well, you write some brief history and said, PUD, endoscopy found a lesion. We treated with a conventional treatment for, say, 3 weeks, 6 weeks without results. Then you have to prompt the senior man and say, well, there could be a possibility of amyloidosis. Then the senior man will now, apart from whatever he's going to do for the normal PUD or a biopsy, endoscopy biopsy, the senior man is going to say, okay, I'll do that, but I was also further, based on the brief history given to me by my colleague. And if you want to be a good doctor or a good clinician or a good professional, you called him on phone and say, well, this is what I found. I've treated for 3 weeks, 6 weeks, no results. This is what I'm thinking. Could you please, let's do that. Then you discuss it with him. Then now he's going to look for it, because we say where the brain it's not expecting, the eyes will never see it. So the senior man now will look at it and tell you, oh, hang on, it's amyloidosis. So that will form diagnostic related, and that will also form the basis of screening. Let's give another scenario. Someone present with intractable diarrhea. My time is up. Oh, okay. Good. Then let me quickly finish. Thank you very much. And it's good you did that. So it means that when you suspect that you do endoscopy, the endoscopist write a report and say skip lesions. Skip lesions, I think I was able to explain. That means that you do a session. Session is, you've got a lesion there. You go to the next session, it's normal. You go to the next session, that is skip lesion, and then this is your suspicion. It's continuous, there is no skip lesions. You suspect inflammatory bowel disease. So you are just thinking only between Crohn's and then ulcerative colitis. Okay? Or pseudomembranous colitis. Okay? You give it to the brother. You said, oh, okay. Because of what I know, we can also screen this patient for amyloidosis. Thank you very much. It's been so interactive, and thank you very much for it.
Welcome him with another hand of applause.
Yeah, thank you very much. You have heard about heart-related significance of the 3 most common ATTR subtypes. And if you look around the three most common ATTR subtypes, you will appreciate that if we want to talk more as in West Africa, as Ghanaians, Ivorians, Guineans, and so on and so forth, our focus will be on TTR V122I. So, this is what the group did. This is what we did as a group. We looked into synthesizing evidence to see if there is any significant association between TTR V122I and heart failure. That is what we did. Evidence synthesis will often require that you search for information and synthesize based on available evidence. So, of course, the studies are many. When you do your search, you will likely find even thousands of studies. But at the end of the day, you must have your goal, aim, objectives. And that will inform a selection criteria. So based on our selection criteria, we identified 16 studies that met our selection criteria. The 16 studies have 17 data sets. Clearly, what it means here is that one of the 16 studies has 2 data sets. Per distribution of the ATTR subtypes, amyloid subtypes, 1,553 are patients with TTR V122I. 1,787 are patients with or living with the wild type ATTR amyloid subtype. Then we also have non-amyloid participants. A huge number of 148,889. Please, these are totals from the 16 studies or the 17 data sets. And I strongly believe that as clinicians, as health workers, health professionals, should you see this, and whatever conclusion might come with it, you will likely want to accept it or welcome it, because the numbers are quite huge. Now, out of the 17 data sets, 5 reported that all study subjects had heart failure. 4, now we want to look into the numbers. Look at the number here, 1,553. Heart failure, 478 TTR V122I patients. The remaining, we said 5 data sets. So minus 17 minus 5 gives us 12 data sets left. The remaining 12 data sets showed reports of TTR V122I with or without heart failure. for 1,064 patients. So we are saying that the 12 data set, this is the number of patients in there, which 513 had heart failure, and 551 were without heart failure. Then we also have 6 reports, or 6 reported, that is 6 studies, reported what Dr. Yao Edubuache discussed at the end of his presentation. The New York Heart Association heart failure classification. So we looked out for that as well, and we realized that 6 of the studies reported NYHA classes 1, that is stage 1 to 4, for 787 TTR V122I patients, of which 43 had the class 1 staging, and the remaining 702 had greater than or 2 stage. I hope it's clear. Good. Now, with reference to the 12 data set that reported TTR patients with or without heart failure, 5 reported heart failure in TTR V122I and the wild type variant subtype, of which 301 of the 377 TTR had heart failure, and 955 of 1,787. These figures. Let me refer to these figures. And you see, in studies of this nature, this is what we did. You could, depending, when you are comparing 2 variables or factors, you will, what is of interest to you becomes your experiment. And the other one that you want to compare your experiment with becomes your control. So we did look into controls. We did look into controls using the wild type ATTR subtype and also using the non-amyloid participants as controls. We also looked into 3 data sets to sort of look into mortality. Of course, if one or a patient has a particular subtype, he or she will also be looking into how long they will live. Not so? So we decided that we will also look into mortality cases of death. And here, 3 data sets with hazard ratios for 320 TTR V122I patients and 934 patients with the wild type at risk of death were analyzed. How did we do the analysis? We used odd ratios to measure association between the ATTR subtypes of interest here and the various variables we sought to look into. So, of course, some statistics. At a confidence interval of 95%, These are the observations we made. Insignificantly lesser TTR V122I association with heart failure than those without heart failure. So here, the comparison has to do with just patients with TTR V122I, with or without heart failure. And we wanted to look into how that affected them. So we realized that with or without heart failure, there is an insignificantly lesser TTR V122I association with heart failure than without heart failure. I hope this it's okay with you. Then, a much greater and statistically significant TTR V122I association with stage 2 or higher than stage 1. That is another key observation we made. Then also, the significance measure here has to do with this. What is here is the p-value or the odd ratio. This is the p-value. And see, so this is huge. We just need something less than 0.5 to conclude that it is significant or not. But see, 0.401 less. So that's why we think, or we concluded that it is much greater. Much greater. Kindly have a look at the value. 219 odds of association. And also, more significant heart failure association with TTR V122I than non-amyloid control. In addition to this, we realized that the wild type, subtype, and control subjects, TTR V122I was shown to significantly predict reduced overall survival of TTR patients, yielding an overall prognostic effect analysis as shown here, hazard ratio of 2.45. What does this tell you? It means that, this is the implication, hazard ratio with reference to mortality, TTR V122I is showing a higher and significant association to mortality compared to the wild type. So from the summary, these are the things we sought to do to measure association of V122I with heart failure. And then measure the association of V122I with the New York Heart Class 1 and 2 or greater than 2. And then to compare the association of heart failure in V122I and ATTR wild type subtype. Also, we resorted to compare the risk of death between what? V122I and wild-type patients. This is the overall goal of the exercise, to assess the susceptibility of patients with V122I amyloidogenic transthyretin variant to heart failure and risk of death. That is the overall goal of the exercise. What will follow next are figures, our plots, to show what we have been discussing, or the summary of our findings. This plot is referred to as the forest plot. What is here is referred to as the forest plot. And here we are looking into heart failure, no heart failure relationship. And these are the figures. For the variant, V122I, with heart failure or without heart failure, is what we are looking out for here. And of course, this is less than, the overall effect is less than 1. What that means is the association relative to heart failure or without heart failure is less. It's less. But, and then we also want to know, if it is less, is this significant at all or not? And the answer is here. P-value greater than 0.05, not significant. Yes. And then the objective, still on objective. You'll see class, this is our interest, of interest to us, compared to class 1. The value we talked about, overall effect of 219.06. What this tells us is that there are 219.06 times higher association of the V122I with a heart failure stage 2 or greater than 2 compared to heart failure stage 1. Quite high. And clearly tells us that we need to pay attention to looking into heart failure when we are managing cases of ATTR amyloidosis, especially patients with the V122I variant. Of course, highly significant. Then, regarding please help me with your regarding comparing V122I with ATTR wild type, let me be honest with you. This study was done with data up to March 2022. At that time, the set nomenclature committee rules was not published. So you will realize that we have WT-ATTR compared to the V122I in the graphical analysis. Obviously, this must be reviewed. We need to review this. So, reference to comparing association of heart failure with the V122I variant and also wild type subtype. This is what we observed. 1.454 higher odds of heart failure in the V122I variant compared to the wild type subtype. And see, significant or not significant? Significant, right? Yes, because this is greater than, it's far less than 0.05%. And then the non-amyloid control. We have done it for wild type. Now, with non-amyloid control, is even higher. And that makes sense and is convincing, isn't it? Because wild type is a disease case or situation. So when you compare, most likely might be same or some amount of difference. But if you decide to compare with a healthy person, you will expect that there will be a much difference between them. And that is what you will find here. 1.62 odd of heart failure in V122I compared to the non-amyloid controls. Again, please go back. See the p-value. Let's compare it now forward with p-value. So that is evidence. That is evidence. Next. And these are the authors. It is very important in such analysis. You need to acknowledge your source of data. So these are authors, and so you find per study and the overall effect. Then we decided to look into mortality for our variant of interest, the TTR V122I, and also the wild type. And this is what we observed. This time, death or mortality. And we realized that death, which is of interest to us, has the odds of 2.45 times that of the wild type. Now we want to look into significance of our observation, and we have p-value of 0.03. Significant or not significant? Yes, please. So that is the beauty of systematic reviews or meta-analysis. We felt that I already promised you we will be doing more of these to support decision making as far as amyloidosis matters to us in Ghana, in West Africa. And this is an example to showcase what to expect. Yes, please. Thank you very much. That is it. That is it.
All right, a bigger hand for Dr. Kak. So our snack is ready. So we'll go for a snack break. Then we'll come and take 2 last ones for the day. Yes. Prof will come and conclude because we interrupted Prof a bit. So Prof will come and conclude. Then Dr. Kak will now take us for what? The almost 3 decades data. Then we'll call it a day. All right. So snack is ready.
This one has been done. So it makes your autonomic policy. Okay, bro, push.
Hello. Welcome back from the snack break. Yes, so we have 3 more to go, but 2 are very short. So the person to take us through the neurologic related significance is Dr. Gloria Chim. So let's welcome her with a hand of applause.
Thank you. So we actually realized during the snack break that we had jumped one. I can assure you it's going to be really brief. Just as my boss, so Professor Tebri won't be my senior because I didn't go to Prempeh College, but he will definitely be my boss. Way boss. But so when it comes to the neurologic related significance, we are looking at how much the neurological symptoms contribute to the symptoms of amyloidosis. As, again, my boss, as Dr. Edubashi, the cardiologist, talked about, we can agree that cardiac symptoms form a greater part of the symptoms in amyloidosis. But I'm here to also tell you that for most of the patients who have cardiac symptoms, before the cardiac symptoms develops, there's usually about 5 years interval between them having neurologic symptoms. These neurologic symptoms, I'll talk about, an example is autonomic action. Yesterday we talked about this, how to investigate some of these things. When we talk about the autonomic action or the autonomic dysfunction, we're talking about patients who come in with diarrhea, sometimes they come in with abdominal pain. You cannot really pinpoint exactly what is going on. They may have constipation. Commonly, we know autonomic dysfunction to be associated with cardiovascular, so patients who are not able to maintain a good blood pressure when they move from either a lying position to a sitting or from a sitting position to a standing. That's the most common way we know it. To us clinicians, that would be orthostatic hypotension. So typically that is what the patients will present with. And we found out that patients who have autonomic dysfunction, if they have cardiac impairments with it, the prognosis is generally bad. The next one I'll talk about is polyneuropathy. Again, we saw that for most patients with amyloidosis, neurologic symptoms form a big part of the symptoms they present with. And as I've already said, it mostly predates most of the obvious ones they have, because you realize in our African setting, somebody has peripheral neuropathy, most likely numbness or tingling sensation. They might not make much of it unless they are paying much attention to it. They'll say, when I wake up in the morning, my fingers are numb. Our patients come to us a lot to complain about it. But somebody might have been going on for 5 years, they won't make much of it. So clearly you can see that most of the time, these are warning signs of things that are to come. But we don't pay much attention to it. It goes on for a very long time until now it moves from it being just sensory, that is what they feel, to motor, where now they might have difficulty moving the part, or they develop some symptom from other organs, example, cardiac symptoms. The other important thing I also want to talk about is when you look at the polyneuropathies, we realize that polyneuropathy mostly is peripheral. So it talks about the peripheral nerves. But most of the time, the disease progresses from the peripheral nerves, goes to the the spinal cord before brainstem and eventually the brain. And my prof here, the pathologist, we're actually talking about this where when it gets into the brain, we have found cases where the amyloid deposits are found within blood vessels in the brain. So commonly you find patients who come to your clinic, they have a stroke. You get the opportunity to do a CT scan. Say there's a positive history of hypertension about 5-10 years. But research has shown us that hypertension bleeds have specific places in the brain that it occurs. So if I do a CT scan for a 58 or 60-year-old man who has hypertension and I see the bleed in the basal ganglia, internal capsule, within the thalamic area, it's pretty consistent with what I expect in a hypertensive. But the moment the bleed goes outside those areas, so I do for the same patient with a history of hypertension, and then I find the bleed in the occipital area, that is out of the range for hypertension. I find it in the temporal area, that is out of the location for hypertension. That should prompt us to think about things like amyloid. Because for most of us, and I was actually telling Prof that for me throughout my training, the most common thing we talk about for amyloid is cerebral amyloid and angiopathies, which is involvement of the blood vessels. Once that occurs, the blood vessels become very easy to rupture and they mostly come with hemorrhagic strokes. But again, we look at pattern, what we know, how it's supposed to look like, and anything that forms outside the norm, we're saying that let's think that these patients could actually have amyloid. Because for most of these patients, if they survive and you go asking them about peripheral neuropathy, if you ask them if they have any autonomic dysfunction, sometimes you might even catch the cardiac symptoms as well. Thank you very much.
Hello.
For those of you in the classroom, are you not behaving like your students when they are tired? No, I can't just give the mic like that to Prof. Please, give a hand. Welcome, Prof, for the next presentation. We just learned this morning that clapping is an exercise. Make it stronger.
Hello. Thank you. So lovely. Where is Dominic? Is Dominic still here or he's gone back? He didn't come today. Oh, okay. I think the last one to talk about is renal diseases. We know the proteins can be deposited into the kidneys and then cause renal problems. So with the renal problems, of course, there are a lot of factors. In Ghana now, galamsey is coming in with heavy metals. So if you exclude everything, looking at the age, it's not been, of course, not necessarily being there because we are drinking the same water. Whether they are able to purify it to 100% and remove all the heavy metals, we don't know. But after you've done everything, you exclude everything, the next one, unexplained kidney failure, the next thing you think about is amyloidosis. Now, so we finish with the diagnostic related amyloidosis. Then we come to treatment. As we've all heard from previous presentations, there's no specific treatment. It's management. And then once we are able to identify the disease, then lifestyle changes put the patient on the relatives or the offspring on the radar so that you'll be able to pick up the disease early and then manage it. When you're managing any condition, we've listed all of them, and it's not responding to conventional treatment, then something should prick you and say, no, hang on, can it be amyloidosis? And that's where you go in to do more investigation, confirm the diagnosis, and then you use the diagnosis as a screening tool for existing relatives and then future generations. Thank you very much. If you have any question, then I will answer.
Hello. They are becoming happy. Please, questions time. If you don't ask questions, I will just be standing here and waste 5 to 10 minutes. Where is Dr. Kak? He should come and take the last presentation. Dr. Napo, where's your... Look for him.
Yes, maybe he would come. Let's wait for him. His own is recap, and it's more of literature. What has happened in so many years about the ATTR amyloidosis. So when he comes, it would flow with that. But when I was writing my summary and trying to close, I saw it more academic. So I think I exempted that area. What I would do is, as they go in to call him, I will see how I can do some summary. And then when he continues with what he has, then I do closing. I hope it's clear. Okay. So far, what have we done as far as the ATTR amyloidosis is concerned? We have been told that just the abnormal protein that is so difficult to dissolve. In other words, cannot be broken down into this normal protein. And so it can cause dysfunction to the organs and then tissues. And when that happens, we have what we call may result into ATTR amyloidosis. And of course, we know that it's rare disease. Is that not the case? In fact, not common to the health professionals as well as we, the citizenry, right? So if something is not common, what that means is that even attending to it, treating it is difficult. Screening it sometimes becomes difficult. Diagnosis is difficult. And that is the story of ATTR amyloidosis. And so what that depicts is the fact that what we have been made to know is that even with the prevalence, we have 2.5% in 6 West African countries. So if you imagine this thing, in West Africa, 6 countries, which is Ghana, Nigeria, Guinea, Serra Leone. Yes, come here. Okay, I will excuse it here. I will continue, okay?
This is for me. Thank you. Good afternoon. Good afternoon. This is session 5. If you have followed the program, this is our last session for a 3-day program with a focus on raising awareness, Transthyretin Amyloidosis here in Ghana for West Africa. We have done a lot, and we now want to render an account of reports on the 3 most common ATTR subtypes in the world. And we know we are part and parcel of it. So that, for interprofessional collaboration, we did that yesterday. So I will give an account of 3 decades of work. And the question will be, is it really 30 years? Is it really 30 years? The answer is no. And for that reason, we said within 3 decades. So I will be giving you 28-year account of reports on the 3 most common ATTR subtypes. This is the take-home of this talk as follows. 1, you will take note of when the first report of original studies. So reviews not part, but original studies on the 3 most common ATTR amyloid subtypes with a focus on prevalence, clinical outcome, and mortality recorded on the PubMed database. So the question now will be, in which year was the first report documented on the PubMed database or search engine? Then we will also look into the distribution of the study reports on prevalence. So if we look into prevalence, how many? And within the how many are studies of, say, only V122I, only ATTRW, only V30M? How many? How many do we have, say, V122I and TTR30M? We will see and appreciate. Then we also look into a trend in all the reports that met inclusion criteria count for the past 28 years. Then case reports, which I want to task and pray, hope that someday Africa, West Africa, will be given some case reports on ATTR amyloidosis. We will get to know when the first case report was made and how many were made in that particular year. And once we are done with this, the distribution of original study reports. This time, we want to know how many African countries have given us some reports. How many? Out of 399 studies, original studies, how many from Africa, and which country in Africa? The question will be, how did we look into this? This is what we did. The first authors are affiliating institution. The country in which the first author affiliation of institution is located is what has been documented here. I hope it's clear. Thank you. So once we know about the countries, we can also look into continents, continental distribution, to see how Africa fared. And once we do this, finally, we should know about amyloidosis centers. Here you will get to know the centers, about 17 centers, and countries where they are located. And also I appreciate their contribution to the 399 reports and discussion. So here, as I said earlier on, mortality, prevalence, clinical outcome. Now take a look at D. D talks about combined A, B, C, or A to C. What does it tell you, or what does it tell me? Obviously, we did the study for the 3 variants or ATTR subtypes for only mortality. And this gave us a total number of 125 reports, distributed in this pattern for V122I, 25, the V30M, 44, the wild type, 74. So it tells us that with reference to an account of reports on ATTR subtypes, there are more on what? The ATTRW subtype, followed by the V30M subtype. And lastly, of course, that is ours. Lastly, the V122I. So you will see same trend here. Take a look at prevalence. We have 249 reports. These are independent reports or studies, as you can see. So for prevalence, we have a total of 249. Out of this number, again, wild type is dominating, 110, followed by the V30M 105, and then we have V122I. How many studies? 68. In fact, let me take a careful look at it. Yes, this is 68. Then we come to clinical outcome. 25, 80, and 87. So if you take a careful look at the studies, you will realize that most come from the wild type subtype, followed by the V30M, then lastly ours. So we should feel challenged to look into that. Hello. The distribution of the studies. As you can see, this is 3. Honestly, if you add them up, first study was in 1995, just one. 96, 97, 98, there is nothing. Then you go to 99, you will find one. In that trend. But overall, you can see that there is a marked increase, especially with some dropped in certain years. But if you look at the entire study, you can appreciate. See here, just in 2023 is not ended yet. This is work up to May 2023. And I can attest to the fact that more have been added for June and July, August, and September. There is a way of monitoring this, and this has been done. So I am able to see, or we are able to see, new studies that are relevant to work we have done. And so it makes room for us to keep monitoring. In fact, they send it to our emails. We have a setting that makes it possible for them to send it to our email. So just up to May, just within 5 months of 2023, we already recorded, or we already have a record of 27. Now to the case report. So we know that we have 399 studies. I hope you saw that in the Venn diagram for the combination. There, please go back a little quickly. Back, the Venn diagram. See, in combining this, you know what is happening is that if you add 249, 125, and 183, you will get greater than 399. So clearly, there are studies that are common to some of the the clinical parameters. I hope it's clear. So we decided to combine and then possibly merge. So if we realize you appeared there, we just put you here. In that order. So this is the total study. Now, out of the 399 studies that we looked into, there are 16 case reports. 16 case reports. And you can see the distribution. It started in 2001, 2 case reports. Then in 2002, there is 1. But you realize we have highlighted this with red ink. And you will be wondering what that implies. It means it is a contribution from an amyloidosis center. That is a contribution from an amyloidosis center. So, yes, and what is this center? That is the Amyloidosis Center at Boston University School of Medicine. You see? And there is another one here in 2019. So Boston, the center in Boston University School of Medicine, did some work. They started one and reported in 2002, and then again they made another report in 2019. That is it. The rest, as you can see, 2001, 2002, 2003, way to 2009. No case report. No case report. Then 2010, another one came. In that order. But look at it. So interesting. 2023, within 5 months, we already have 2 case reports. Obviously, it is improving. Reports are being made. People are encouraged to make more reports. Hello. Thank you. Now to the countries. To the countries. To the countries. We here, you will see the country, you will get to know how many reports they have to their credit out of the 399 reports. And obviously, the United States of America is dominating with a score of 103 reports out of the 399. Followed by Japan with 50. You compare and you realize that it's about half of that of US, about half. In fact, less than half, because we are looking at 103.50. 50 times 2 is 100. 3 more. So half plus 3. Then the next is Italy. Italy has 35. In that order, followed by Sweden, 31. France and Portugal, 30. United Kingdom, 28. In that order. So you can see, with this chart, we refer to it as the Pareto chart. Pareto chart helps us do some ranking. And as you can see, you will appreciate the ranking. And at the far right corner, you will see some percentages. It gives you a fair idea of the percentage difference in the ranking. So see, let's use this as an example. See, less than 50 when we compare. And that is how the Pareto chart helps us appreciate ranking of data. Thank you. Now you saw the countries. Did you see any of the 54 African countries in there? No. So we go back to look into continental data. That is, of course, 399. That is it here. And also looking at reports based on the ATTR subtypes. And you have ATTR wild type only. As in, you saw the Venn diagram. And we know that in Venn diagram, we know where to put only, where to put intersection, or depending on the set problem. In our case, 3 set problem. So look at Africa. Look at Africa. For all the subtypes, and combinations, as you can see here. There's nothing there for us. Not even the V122I. That is the situation in Africa. Then next is Asia. Asia, this is the distribution for about 58 studies. Followed by, we also have Europe. Europe here, this is the distribution of the ATTR subtype. And as you can see, Europe has done something big here, which is about 214. North America, that is where we have, well, you know, the United States of America is North America. See, it's about 108. And out of this 108, we already know that 5 is coming from what? The USA. I mean 103 from USA out of 108. Then Oceania, just 3. South America, 16. And this gives us a fair idea of the total. Then again, look at this. What does this one mean? It has to do with the hereditary and with the wild type. Then, only hereditary seems more than wild type. That is how it works. Next thing is we need to appreciate how centers work, especially when we know that is the only or best way to diagnose ATTR amyloidosis. Centers are the best alternatives because we can have such diagnosis happening like we do for malaria. You know, in malaria, every hospital does it. But we can have that for ATTR amyloidosis. So it is obvious that centers are needed. We don't have one yet. But we want to appreciate those who have and what they have been doing and hope that it motivates us to do same or better. And with this in mind, you will see this as a country contribution, and also you will see how many centers are in that country that have contributed to what? The reports we are discussing. In fact, all the centers, about 17, gave 61 reports. So out of the 39, 61 is coming from what? Amyloidosis centers. And we already know how many of the 61 are case reports, don't we? 2 are case reports. So these are the centers. 1 from Brazil, France, 3, Germany, 2. Italy, 2. Japan, 1. Portugal, 2. Spain, 1. The United Kingdom, 1, with the highest number of reports. Out of the 61, NAC, which is the National Amyloidosis Center, gave or produced 20 reports out of the 61. That is about a third of the reports generated. And that is United Kingdom. So you will see and realize that the number of centers does not really matter. It is not about how many centers you have. Because see, we have witnessed a country with just 1 center, but yet it is recording the highest compared to others with United States of America, 1, 2, 3, about 4 centers. But the sum is just 11. Okay? So, as Africans, or West Africa, our concern should not be numbers. If we can get 1, that should be enough to keep us going. That is the motivation we can draw from 1 center in the United Kingdom. Thank you. You saw the names, the centers. We only gave the acronyms. I mean abbreviations. But it is good to know the full name. So we have created a legend here for you to appreciate the names. And so, NAC here, which is of interest to us, as I explained earlier, is the National Amyloidosis Center. Boston is also here, and that is Amyloidosis Center, Boston University School of Medicine. That is also here. And the others, okay, in that fashion. But if you count 17, next. Thank you. You know, earlier on I did mention that we characterize the studies, subgroup them into a term based on clinical characteristics that are of importance to any amyloidosis patient or any researcher who wants to go into amyloidosis research. The 24 are nicely placed here, and some of them have been discussed. Aortic stenosis was discussed. Dr. Yao Edubuachi did some work on that for us as part of discussion. And the applications of diagnostics has also been tackled today by Prof. Stephen Tabi, and arrhythmia has also been looked into. Same. We have also looked at atrial fibrillation, autonomic action. You witnessed that a few minutes ago. And cardiomyopathy, CTI, you remember, when we were looking into early detection. That is what the carpal tunnel syndrome. Then case reports. So you will see the distribution. Looking at it, this is what happens. If you compare polyneuropathy with cardiomyopathy, look at the figures. 37 against 79. What does it tell you? It tells us that the focus should not be limited to only cardiac. Because the report points to the fact that polyneuropathy is giving us more and needs attention as well. And we hope that our neurologists will be encouraged by these figures and possibly also pay much attention to ATTR amyloidosis management. Thank you. Next. The legends have been explained. Now, out of the clinical characteristics, the focus has been on the three most common ATTR subtypes. You remember? Three most common ATTR subtypes. But we made some observations in our study. We realized that some other TTR variants were discussed alongside the three most common ATTR subtypes. And that is it here. Case reports for some other subtypes. Please go back. Take a careful look at this. Take a careful look at this. Take a careful look at this. That's how it works. Please, next. Yes. Good. These are not packed. This is not packed. A30P. Not packed. So, in that order, mix of other TTR variants that may be of interest to us. That is it for within 30 minutes. Within 3 decades, within 3 decades of what ATTR report. That is how the picture looks.
All right, we can do better. A louder one. Yes, so that brings us to the end of the presentations because this was done yesterday. I know as I was sitting and thinking, we're all thinking, hey, but where is Africa? So it's now time for questions and contributions to this last presentation. You kindly write your question. If you have a question, write and raise your hand, then I'll come for it.
Yes, somebody wants to look into clinical outcome. What does per the study, when you hear clinical outcome, what should come to mind? Clinical outcome here focus on a measure of the symptoms or other associated conditions, such as the characteristics we mentioned. As in, a patient has ATTR amyloidosis, and an outcome could be how many TTR variants are in there. Compound, is it compound heterozygosity? That is an outcome. The patient is has ATTR amyloidosis, right? Does the patient suffer from any other cardiac disease? Aortic stenosis, lumbar carpal tunnel syndrome, lumbar, what is LSS to us? Lumbar spinal stenosis. Then we also have the carpal tunnel syndrome. These are all clinical outcomes. Is that okay? So yes, that is it. So he's asking me to kindly define clinical outcome. The clinical outcomes are expected signs and also other non-communicable diseases that are known to be associated with what? ATTR amyloidosis, especially the red flags. And so researchers would want to know which of the flags are showing, which of the red flags are showing, and other non-communicable diseases that might be associated with the known one or key disease of interest, which is ATTR amyloidosis. Okay, thank you. Any other questions can come? Welcome, most welcome. If you have any questions, please ask. Yes.
I think my question goes to Prof. Tabri. Yeah, I think from the beginning we did mention that once the deposit has occurred, we can't reverse it, and that's why we don't have treatment. But then we mentioned that we can either slow or prevent the liver from producing the misfolded proteins. So from the treatment, I was looking at maybe mechanisms that we can adopt to slow the progression of the deposits. I don't know if you get my question.
I do, but I'm thinking how I'm going to. Do you want to help me?
I think this is suggestion. As he's thinking, I'm also thinking. But it's not just amyloidosis. A couple of diseases they don't have treatment. But since the focus is on the liver, then there are some things we call hepatotonic. Something that can help your liver to remain active and support metabolism as much as possible. We do that in hepatitis, for example, hepatitis B treatment, where there are drugs, but we know those drugs can only manage, they can't cure hepatitis B. Once the liver damage is assessed, then you can now say, okay, let's support this with some things that can cause some regeneration in the hepatocytes and will support the metabolism activity of the liver to a greater extent, such that the liver will not suffer the damage as much as possible. That's on one side. But the other side is lifestyle also modification. You remember, whether it was the first day, I mentioned something like, if you already have this deposit and you take alcohol, you are going to add more insult to the liver. And so such people will go down faster than somebody that is not taking alcohol. So lifestyle modification, some drugs to help the liver to remain active and support metabolism. And you remember also that there was liver transplantation as an option. But of course, before you do liver transplantation, which is not available in our part of the world, before you do that, you have to do a lot of genetic testing and find to what extent that has gone and all that and all that. And the cardiologist mentioned that you could do heart, liver. All these things are big, big things. I can tell you in West Africa, liver transplant is still, I think, where is the person from Côte d'Ivoire? I think they did one recently in Côte d'Ivoire that was celebrated with some support from Egypt and all that. So we are still struggling with liver transplant, talk less of going for heart transplant and all that. But lifestyle modification, something to make the liver alive. And there are a few drugs that they call hepatoprotective or hepatotonic that they help the liver to remain functional. Thank you. Maybe you had to.
I think I'm trying to check, but I've been able to confirm that there is no specific treatment. You can use other drugs to slow it down, even with a transplant. Once the person is diagnosed and is doing, once you transplant, it's also going to fail later because the deposits are going to continue. So that is why the emphasis has been early detection and management and screen. If you detect it earlier and the person is drinking alcohol, you'll be able to say, well, stop it, or it's going to progress faster. So there's no specific treatment, but there are proposed treatments to slow down the deposit. That is all it is. That is why it's important to know it earlier. Thank you.
Dr. Kaka.
Thank you. Is there any point to reduce or stop production of amyloid fibers? This question tells me a lot that you have followed through, and I really appreciate that. But to appreciate the need to reduce or stop amyloid fiber formation, this is what we need to bear in mind. The more deposits we accumulate, the lesser our survival window. The more amyloid fiber deposits we accumulate, the lesser our survival window. With this in mind, it is obvious that first we need to detect it early. As in, once the fibers start accumulating, the earliest, the best. And once we do this, I will say, let's buy time. And let's buy time here means we will simply slow it down. And if we can stop it, we will stop it. I don't know how you feel, but to be honest with you, when death stares at you, 1 minute, very important. Thank you.
All right, so okay, a last question. Are you writing? If it's for Dr. Kak, you write it. It's for Prof. Dr. Kak. So you write it. Not so much about what is writing.
Okay, thank you very much. Thank you very much. I will read out the question here. Very, very interesting question with reference. What point is it advisable to take a biopsy during the workup? I like the language. Yes. The person asking is really following us or has followed. And then, second question is, what is the diagnostic test for ATTR amyloidosis? Gold standard. For reference to ATTR amyloidosis diagnosis in our settings, it is not different from any other place. But it depends on what we have available. Available infrastructure for diagnosis is what we should be looking at. All that is done everywhere is near the sea. There is no way you can go below. But then, this is how you will start. We have mentioned or discussed some symptoms of or signs, red flags of the condition. So, if you observe that a patient comes to the clinic and always reporting of carpal tunnel syndrome, there are other cases of lumbar spinal stenosis. These are very, very common bone diseases in our settings. And I know I have a case of that nature where somebody suffers lumbar spinal stenosis and also has issues of hypertension. With this, and you are possibly administering treatment, and you are not getting desired results. You are not far from wanting to look into looking out for amyloid fibers in the patient. And this, you just can do a simple Congo staining test. And with biopsy sites, the abdominal wall is fine. It's fine. But of course, we can also pick from the bone marrow, especially if the patient already has some challenges with bone. Again, if a patient has challenges with bone, it is very likely the specialist will likely look into tendons, ligaments. So we might see some deposits of amyloid fiber in tendons and bones. All these will help. But the problem is this. Even if we identify the amyloid fiber, the question of whether it is hereditary or wild type is a challenge to us. That is the challenge. How do we do that? It's the challenge to us.
Thank you. It is a contribution about the treatment. So I think the next step after this, after the awareness, will be for us to work to establish the real prevalence of the disease. And this could help encourage the research about treatment. So here we are indirectly working on the treatment.
Thank you.
Yes, there is another question here. Oh, okay. That the center in London licensed a drug called tafadis for prevention and then, for prevention. So he wants him to talk about it. Prevention and stabilizing the Transthyretin protein. Prevention of the misfolding and stabilizing Transthyretin protein. Can you talk about this?
Very interesting question or suggestion on what we should do. He is saying that where is the National Amyloidosis Center in the UK found? It's in the center of UK proper, London, and in a university. Okay. So our universities are challenged to consider doing this for us. And he did mention a drug for treatment of amyloidosis, tafamidis. Yes, tafamidis is a very common and effective drug for treatment of amyloidosis. But the work itself on tafamidis was done by Scribes Research in the US. As for licensing it, the US FDA already did that. And there is a lot of evidence to show that it is doing well as far as treatment or managing ATTR amyloidosis matters. So I agree, but it is not only the National Amyloidosis Center in the UK that recommends use of tafamidis. It is about the best in the system now, except that it has some limitations. As I mentioned, our headache, our greatest headache now is when we have the deposit, we can't take them off the organs. But some work is going on at phase 1 clinical trial, where they have been able to develop something that has shown to remove deposits. But it is stage 1 treatment cannot be used in hospitals, as he said, licensed or now in use in the UK. That stage, we haven't gotten to that stage yet. We are just at the start of things. Yes, he is saying that given the meta-analysis data presented so far with the clinical suspicion deficiency in our settings, can we say that ATTR amyloidosis is a silent epidemic?
Okay.
Thank you.
Shall we
Frankly
clap for?
speaking,
Shall we clap for?
speaking, this is of a great concern. It is of a great concern. Thank you.
So we continuing, and what we said was we've conducted the research, and with this, normally the research we conduct for in epidemiology, we will say they are very analytical. So we use the case control cohorts and then the random control trials. And you can see that the variant that is most common is the V122I. And you can see that in West Africa and right from the other countries too as well. And when he did the account, we could see it. What we should also understand is that as far as amyloidosis is concerned, we need to do screening. And this screening would help us to be able to do diagnosis. So we stress on the point that screening is very important and we cannot relent on that. Again, what we have done is to also drum home to the fact that genetic counseling is also important, because if it's going to run through the family and nobody is aware and we are not able to interject it with counseling, we would really have a case to answer. So we are saying that we need to cultivate the habit of doing what we call genetic counseling. Let them know that this thing is possible to affect the entire family because one has it. So we need to reduce the risk of that. And if I say that, it means that, as Prof said, sometimes there are risk factors, the alcohol and what have you. We need to be very careful. In everything, even the chronic diseases, there are risk factors. And if you look at the types we have so far, some of them you could see that it's related to age. Some of them too, we could see that it's just a matter of race because it is rampant in certain parts of the countries. So we need to know that in terms of race, in terms of age, in terms of sometimes the other chronic disease you have, it's even a recipe for disaster as far as amyloidosis, ATTR amyloidosis is concerned. And so the types we have the AL amyloidosis, which is the primary amyloidosis. We have the AA amyloidosis, which is the secondary amyloidosis. We could also have the TTR amyloidosis, where we talked about the hereditary and then the wild type. And then we talked about ALET2 amyloidosis. So these are the four main amyloidosis or most common amyloidosis we have. You can scroll it. We have. And now we need to also understand that as far as amyloidosis is concerned, there is no center in Ghana. There is no diagnosis center in Ghana. It's obvious whatever we have done. There is no diagnosis center in Ghana. Of course, we heard a lot about Congo Red. And so if you bound all your hopes that Congo Red is the magic whatsoever, remember that what Congo Red can do is to identify the amyloid fibrils, but cannot identify the type. So let's get it right. And then, of course, we are saying that in terms of diagnosis, I think all our physicians who came here made us to understand that in terms of diagnosis, it is cooperative. It is not one-man shop. Because what is happening here may be the cause as a result of what's conditioning happening here. And for that matter, you need all the specialists to work together. And not even that alone, we need to do what we call interprofessional cooperation. We have made this clear. Let it go on for everybody to understand. So far, so good. We have done a lot. Of course, some are very academic, some are clinical, and we have combined all to get knowledge. And you could see the account he gave, very, 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 very piercing. And this is what the state of amyloidosis in the entire world suggests to us. Now, what you need to know from the ATTR amyloidosis team, please, you can scroll it. What we have done so far, I think I've spoken about this. There is no center in Ghana and West Africa. What I want you to understand is that, one, the main target, the medical grant, it was a medical grant we had situated at the CK Tedem University. Of course, Mayo Clinic is of technical support to us. Now, what are we doing? All these things we've brought people here. What are we doing? We are ensuring to promote early detection and diagnosis, mitigate the misdiagnosis and timely treatment of TTR amyloidosis in West Africa in anticipation of creating a robust West African Amyloidosis Center. Now, out of this, we have formed what we call TASN, that is the support network. And I don't know, but if you are here, you should know that you are part of this support network. If you look at the selection we did, we ensured that each hospital, or every hospital we could get access to, we were selecting 5 people from the hospitals. And we needed a nurse, we needed a medical doctor, we needed a pharmacist, we needed a lab technician or lab technologist. We also needed either public health officer or disease control officer. These 5 people will form the TASN in their various hospitals. And in the university too, we had the same caliber of people. And they would also form what we call the TASN. That is the Transthyretin Amyloidosis Support Network. And what they would do is so obvious and revealing. You are going to continue the training. So this is what we call, train the trainer. This workshop we have done is called Train the Trainer. So we have trained you. Now you being the trainer, you need to go and train. So you replicate. That is why you could see that. And then we've established what we call the TAWN. That is the Transthyretin Amyloidosis. This is workforce network. And what is different here is that this is inter-country. So you could see that this training, we have different countries here. And you remember the countries were those who were recording the prevalent rate of 2.5. So they have come here and they have seen what is going on. And what we are doing is to have that task force inter-country. So they will coordinate activities with the team, the central team, for which I'm part. And then we would also see that the TASN2 would also coordinate with the central team. So that would really enforce whatever we want to champion. And I believe that if we are able to do these things well, that target of doing what we called creating early awareness would be realized. And in fact, would be able to penetrate. And then we have also conducted what we call the pre-test survey. This one, the moment we started our work, we said that we need to know whether there is awareness across board, the whole country. And of course, we did that, and it was so appalling to know that even among the health workers, they are not aware, let alone the normal citizen. So that was terrible. And so we have the result. We have done all these things. Then the next attempt is, now that we have done training, what that means is that we will continue the awareness creation. And so when we do that, and we are going to enforce it with television, we go on television for awareness creation, radios here and there, so you'll be hearing, coupled with whatever you are going to do. And for that matter, when we do all these things, we need to also measure and see the awareness creation has really penned down with the citizenry and then the health sector. When we are able to do that, what we are ensuring you is that we will continue the survey on the website, the EES website. You all have our, we have your emails. You will be sent information, and you will do. And as far as we are concerned, we will still produce what we call materials for you, for your learning and what have you, to aid in our activities. And then we also, as we have seen, we have conducted a train the trainer workshop. We will provide leaflets. Even today, everybody, please sit down. We will do the leaflet. We'll give it to you. These are part of our training materials. You share around. You do teaching. You would encourage people. You will let them learn. You will let them open up to them. And then we urge all of you. We have social media handles, the Facebook and Twitter. Please, from today, this one will be made available. All of you joined. You are part. Now you are part of the ambassadors. So join us. Let's do this thing together. And then you can see that the clinic is supporting us technically. The last thing, take home. I want to believe that the tax, that is TAS, is a must. Do you agree? You all agree? Then you also understand that the TAWN is also a must. Do you agree? Then again, we should also understand that raising awareness for early detection is a collaborative effort. Do you agree? These are take home. And then this one, as you have been trained, so you are trainers, right? Now trainers would also go and train people. It's a must. Do you agree? On that note, I want to bring the whole curtains to a close for what you have done. We appreciate you very, very much. Thank you.
All right. Let's give Dr. Napo another hand of applause. Dr. Napoleon Samuel is the project manager. Yeah. All right. What is left? I have forgotten. Yes, thank you, Doc. The assessment, CS will send a link to our various emails. You will take the posters, do the appraisal, then you print your certificate. Hello? Yes, so CS will send us a link to our emails. You take posters, appraise the program, then print your certificate.
Let me quickly do this introduction. Permit me. I didn't want to come back because I'm a man of the short words, right? We have a team in place. I just want to introduce the team to you. I think you can hear me, right? I just want to introduce the team to you. Obviously, you saw him doing virtually all the training, right? And you know him as Dr. Apia Kubi, Senior, right? He is the PI for Ghana and West Africa entirely. And you saw my good friend, my good old professor, who is waiting for me. Don't say he's gone, he's waiting for me. So, he is Professor Stephen Tebri. I think you know him as the Dean of Medical School, University for Development Studies, where I'm part of him. I'm one of the head of department there, so I work with him. He's my boss. And he is the co-PI. Then myself, I'm Napoleon. B. Sam, project manager. And we have our very nice and cute lady who happens to be a medical writer. So she writes a lot. Okay. Then we want to introduce the clue, our West African reps. Are you okay? To you. So first I would introduce the Côte d'Ivoire, who is in the person of Way Malinier, okay, professor. So let's give her a round of applause. She would mention the name right for you.
Ladies and gentlemen, it was my pleasure to be with you during 3 days. I liked too much everything, and now I'm so sad to go back in Côte d'Ivoire, but it's the beginning of the network, and surely we will keep in touch, Kate and everything. Okay, I'm Professor Melanie Tia. I'm a renal physician, and I'm about the course of nephrology at the University of Alassane Ouattara, our president. And I'm also a renal physician at the teaching hospital of Bouaké. Bouaké is not so far from here. Okay, Berekum, Bonduku, Bouaké. And also, I am the head of the dialysis unit of Bouaké. It was my pleasure to discover the wonderful people of Ghana. Thank you very much.
Now, did you hear? So we now, okay. We now introduce you to, don't worry if I don't know the name, right?
Good evening, everybody. My name is Bengali Traore. I'm coming from Guinea, Conakry. And it was very pleasure for me to join Kwaku in this project. This is my first time to be in Ghana, especially in Kumasi. The town is very nice. The people also. Yeah, we are nice. Okay, thank you.
We have gone to Ivory Coast, Guinea. We will go to Burkina Faso.
Okay, thank you. I'm Dr. Ilbudo Adama. I'm a cardiologist from Burkina Faso, and I'm working in a confessional hospital that the name is Hôpital Polsis. And as he said, it's also my first time here in Ghana, and I have learned many things about, firstly about amyloidosis, and I have met kind people here, and if I get the opportunity to be back here, I'll be back here. Thank you.
Thank you so much. Thank you so much. So you realize that it has been French. Now we will do English.
Good afternoon, everyone. My name is Babatunde Duduyemi. I am primarily a Nigerian, and I started my practice from Nigeria. I was in Ghana for 7 years, Now, this is my third year in Serra Leone. So I'm a West African guy. Yeah. And you can see all the three countries, they are represented here. So I'm probably the most representative of West Africa here. I am a professor of pathology, as you saw from my discussion. I am so glad to come back home because Kumasi is a home. This was where I taught for over 7 years. So, and you can see my dress. I bought it when I was here. So I'm so glad to be in your midst, and I have found the discussion very robust. And I just want to leave a message that, like the project coordinator mentioned, all of us are ambassadors for this neglected disease. And so we have to make it happen. I'm going back home to make sure that we start the network. I've put a team together, but we are going to expand our team based on the teaching that we've got. And Kweku told me that, can we replicate it in Sierra Leone? I said, readily. So we look forward to us also doing this type of training in Sierra Leone. Just my last comment to the project coordinator especially. When we do a training like this, we must not allow it to die. So, Mr. Project Coordinator, I want to put it to you. I told Professor Tabiri, who also, when I was here, we had worked together, that we should write a proceeding from this meeting. You can do a draft. All the people from other countries can add some input, and this can be the first publication on amyloidosis from West Africa. So, not really an original whatever, but at least let them know that we are talking about it and we are making a move. So, I'll be glad to support that as much as possible. So I thank you very much for welcoming me back to Ghana. And I thank all the organizers for a beautiful meeting. Thank you very much.
Unfortunately, our counterpart from Nigeria couldn't make it. Could have seen him as well. So you've really done well. We thank all of you for coming. You are part of the achievements, part of the games. I will continue relying on you. Thank you, thank you, thank you. So, I think the leaflets are here. They will be giving it out. You can see. So what we they will be sharing it. We have enough, more than enough, for your activities, so that you go and do it. Thank you. And they would send you all our Twitter and then the Facebook handles. Please join them and let's propagate. In fact, let's speak, so that West Africa will hear, Ghana will hear. You don't know who might be the cause, because sometimes we don't attend to it. So we need to pray. Let's pray and close. So when you go and get your food, you sort out whatever you want to do. I know most of you will go tomorrow. So, and those who will go today, safe journey. So let's pray. Spirit divine, unto you we call. When we started, we didn't know how to do it. But you, the Almighty God, you have taken us there. We are so grateful to you. I will continue to thank you for every steps you take with us. Lord, we are praying that as we have taken that mandate, may we be able to move with your own direction. Cause us to do whatever we're supposed to do for this program or for this teaching and lectures to travel throughout the sectors we want. May the name of Jesus Christ be our backbone and take us there. In Jesus' name we pray. Amen.